What if we could spot oral cancer before it even starts? Welcome to Dental Talk. I'm Dr. Gary Glassman, and today I'm pleased to welcome Dr. Hagen Klieb.
Gary, thanks for having me.
In today's episode, we're exploring early cancer detection with Dr. Klieb of Sunnybrook Health Sciences Centre. He also leads LifeLabs oral pathology biopsy service with about 5,400 Canadians diagnosed with oral cancer each year. Is this something the average dentist should expect to encounter in their practice?
So it's a good question, and the short answer to that is yes. And I would take that further by saying it's not a question if you will see a patient with oral cancer. It's when and if you're going to be ready. That question brings me back about a year or two when I was giving a lecture, and a rather senior dentist came after and said, that was an interesting lecture, but I've been practicing for 30 years and I've never seen oral cancer. And that same dentist called me a few months later saying, I think there's a patient you better see pretty quickly. And sure enough, it ended up being a precancer. So I don't know if it was just a coincidence or if that lecture opened his eyes to the possibility. But the reality is that there's a misconception that oral cancer is rare. It's not. I'd say it's uncommon. In Canada, there's certain cancers that are relatively common. So lung cancer, breast cancer, we all unfortunately know someone with those sorts of cancers. Oral cancer is less common than that, but on par with things like pancreatic cancer, breast cancer, stomach cancer, which we all know someone, a friend of a friend. So the reality is, Gary, is if you practice long enough, you'll see it. It may not be today, it may not be tomorrow, maybe next year. And will you recognize it? Because if you don't, you're in trouble and the patient's in more trouble.
Interesting. The traditional profile has always been older males who smoke and or drink. And now we're seeing healthier, younger individuals getting oral cancer. Is that due to HPV? Is it due to them using smokeless products like nicotine pouches
Right.
and or vaping as an alternative to smoking cigarettes?
Right. I definitely agree with you that we're seeing younger and healthier people with oral cancer. These are people who shouldn't have cancer, yet they do. Is it related to HPV, human papillomavirus? The answer to that is both yes and no. We definitely believe HPV causes cancer in the back of the mouth, so the oral pharynx, that's the base of the tongue, and tonsils. It's sort of a bizarre way to think of cancers. This is a sexually transmitted cancer. It's spread through sexual contact like oral sex. Once exposed, it doesn't lead to cancer the next day or the next month. It's years, sometimes decades later. But these patients are still young, or at least I think 40 or 50 is still young, if you'd agree with me.
Listen, I agree.
Perfect. These patients, again, they're young, they're healthy. They tend to be, 40 to 50 males. But we do not believe that HPV causes cancer of the oral cavity proper. So the tongue, the cheek, the gingiva. Those sort of patients, however, while traditionally thought of as older people who smoke too much and drink too much, are more and more becoming young, healthy people. We're seeing a particular spike in females around 40. And what's causing it? You better believe that's what they'll ask me when I tell them the diagnosis. What have I done wrong? What have I done? And we don't have a very good answer for it. There's some conjecture. Maybe it's, changes in diet. Is it cell phone uses? Who knows? Vaping, certainly that's become more and more common. Does vaping cause oral cancer? And the answer is we don't know. Hasn't been around long enough. We need something to be around for 30 years. We need to compare people who vape compared to people who don't vape for 30 years. We don't have that data yet. So what we're doing at this point is tantamount to a large population-based study using our youth, our kids.
And are we collecting data? Are you collecting data?
Yeah, absolutely. So every patient who we see who has oral cancer, we document what their potential risk factors are. And, for sure, many patients who have oral cancer, young and healthy, vape, but many don't. So I'm sure there's other factors out there, and we just need time, unfortunately, to figure out what those are.
So other than the presentation where smoking, vaping, they see it in the mouth proper, and HPV-related cancers, they're seeing it in the oral pharynx, are there any other characteristics of presentation and, of course, treatment?
It's interesting. Cancers that are HPV-related are entirely different than cancers than not. It's not comparing apples and oranges. It's comparing, apples and tractors. Cancers that are HPV related What's interesting about them is they tend to stay extremely small in the throat. Sometimes we never even find the primary cancer, but they spread to the neck where they'll manifest as an asymptomatic neck lump, which is why we want our dentist palpating the neck as part of a routine dental visit. Every dentist should be doing that. The nice thing about cancers in the oral pharynx is that they tend to have a very good prognosis, both because the cancers are radiosensitive and the patients are young and healthy and they can tolerate, radiation. The downside or the irony is that these patients have lived for years and years with the cost of survivorship, the negative attributes of radiation, the severe dry mouth, the predisposition to osteoradionecrosis, the inability to swallow. These patients may be committed to a gastric tube to ingest all their food for the rest of their life. So this is a very different story from cancers of the oral cavity. The traditional areas that are involved are the tongue, the floor of the mouth, and these cancers will always start as a precancer, which is a nondescript red or white lesion. You give them time, they develop into an ulcer or a mass. And the treatment of these cancers is really predicated on the stage. The stage is how advanced or how spread the cancer is. Early cancers are treated with just surgery versus the advanced cancers, which are stage 3 and stage 4 cancers, are treated with surgery, chemotherapy, radiation. And to be frank with you, Gary, sometimes we just can't treat patients from the get-go. They're palliative. So we'd much rather diagnose a patient with stage 1 cancer compared to stage 4. But wouldn't you know that most of our patients present initially with stage 3 and stage 4 disease?
So that's interesting. And your research identifies early cancer detection with a specificity of over 98%. But as you mentioned, most cancers are diagnosed at the very advanced stage. So how does this molecular approach decide which lesions need more aggressive treatment versus immediate intervention?
Well, first of all, I'm glad someone's actually reading my studies. I thought they just went into the nebulous of the internet. So
I'm up at night reading your studies, Hagen.
it's good for insomnia. I highly recommend it for that. In a perfect world, I wish we would see patients with precancer as opposed to being referred to us with cancer. But when we do see patients with precancer, almost always what we'll do is we'll take a biopsy. And what a biopsy will do is it'll give us an idea of how precancerous a lesion is. Sometimes the biopsy will come back with a measure we call severe dysplasia, which tells us that this is a high probability of turning into cancer. And we have simple algorithms with what to do. We're almost certainly going to treat patients aggressively with surgery, with close monitoring. The problem is when someone has a biopsy that comes back as low grade. We know there's a low risk, but it's not a zero risk. What do we do with these patients? We don't know. And that's really where molecular comes into play. So in our study, we looked at a measure called loss of heterozygosity, which is an indirect measure of genetic instability. And we found good correlations. We could pinpoint which patients were more likely to turn into cancer. The problem is that we're one research group. We need it recreated across the world in multiple labs. It just doesn't exist. Today in 2025, Gary, if you send me a patient with precancer, I'm going to treat them by biopsy and using that as really the only measure. In 20 years, I think we'll have a lot of molecular tests to put in our toolbox.
Well, you see thousands of biopsies at LifeLabs, thousands over a year. What's causing the delay? Why are they waiting so long? Is there something that we as clinicians are missing and we need to do?
Right. So, Gary, you're touching upon something called diagnostic delay, which is what keeps me up at night. This is the bane of my existence. Diagnostic delay is a real thing with oral cancer, and there's probably not one reason why it exists. It's tempting to blame the patient. So you can imagine a patient of yours, a friend, a family member who sees something in their mouth, who feels something in their mouth. How long does it take for them to see you or to see their family physician? And it can range anywhere from minutes to years. I don't know what drives that. The common culprits are, who wants to face bad news? So there's that denial. There's a knowledge gap. Can you even get cancer in your mouth? Some people may not know this. They may think, man, I'm just biting my tongue. But, there's not too much we can do about that. But, what about when the patient comes to you, Gary, and they show you something? How long will it take for you to initiate a biopsy or refer to me? And that can also range from minutes to years. And that's the real crux of diagnostic delay. Another issue, and I'm almost hesitant to say this, but there's us, the specialist delay. It, unfortunately takes time to get in to see oral pathology. This is just a function of there not being very many of us, and all of us who exist, we all have long wait lists, and that's what keeps me up at night. If I have to call in sick, that sweat forms on the back of my neck. We also have this nasty habit of only congregating in major centers, Toronto, London, across Canada. So what about those poor folks who live, up north? How do they come to see us? And we've initiated some measures where we're doing more and more virtual oral pathology. So we'll chime in directly into a practice and help a dentist who's seeing a patient. I run a practice like that in Sault Ste. Marie with Bridget Lamberts, who's a periodontist. So I've become almost an honorary periodontist, if you will, but she's helping me and I'm helping her.
And she's becoming an honorary oral pathologist.
Correct. Yes.
So how can we train more of mini Hagen Kliebs around the country where the accessibility is so hard?
That's a great question. I was hoping you had the answer to that one. They all want to be endodontists.
Yeah, for sure. And they all want to open up right around me.
Correct. Exactly.
One of the most common things, and I found this on one of my patients, and I referred a patient to you who had oral lichen planus, and we know that oral lichen planus can transform into cancer in about 1 to 2% of the cases, and it's higher obviously when dysplasia is present. What signs indicate that we need to stop watching and we need to start acting?
Gary, that's a good question because everyone has a patient with lichen planus. Lichen planus is very common, and you better believe it when you see a patient with lichen planus. The first thing they're going to do when they get home is they're going to go on Google and they're going to read about lichen planus being precancerous. I have to admit that I recognize in the literature it's considered precancerous, but my mindset to that has waxed and waned. I go through stretches where I see so many thousands of patients in a row and I don't see cancer. And then some weeks I see multiple patients develop cancer. So I do believe currently the literature that says that it's a precancerous lesion. And Gary, my philosophy is, number one, I educate the patient. I'd rather they hear it from me than Google. I tell them about the risk of cancer. And I think this helps with compliance, with follow-up, if they understand why they're coming back to see me or to see you. But the other thing I do when I monitor these patients is I've stolen a concept from our dermatologist colleagues. They use something, if you go for a mole check, for example, they use this ugly duckling phase. They're looking for one mole that just looks different from the rest. And I do the same when I'm looking in the mouth of these patients. I'm looking for one part of the mouth that looks different from the rest. So if one part of the mouth shows like a plaque, or one part of the mouth shows a solitary red area, or even symptoms, it just hurts on the left side of my tongue, I'll take a biopsy. It's a relatively minor procedure. The majority of the time the biopsy comes back as saying, it's nothing, it's exacerbated lichen planus, but every once in a while you'll catch something and that's life-changing.
Would you prefer to do the biopsy? Or would you like your referring dentist to do the biopsy?
Either one's fine. If you do the biopsy, just something that's helpful is a diagram, an X where you took the sample. And certainly it also helps to get the pathology report if you were to take the biopsy. So just so I don't have to go through word of mouth. Yeah.
So leading LifeLabs, you say, thousands of biopsies a year. What are the most common diagnostic mistakes that are being done by the general practititioner?
Right. Well, I don't want to throw our colleagues under the bus because I think in general, dentists are highly intelligent, skilled, motivated. They want to help. But there are some trends that I see. The first thing I'd say, Gary, is that the diagnosis of oral cancer is incredibly straightforward. Most advanced cancers that we see, you can almost spot from across the room, a large mass, a cranioform ulcer, and that's easy to diagnose. Where I think most dentists make mistakes is the smaller, the innocent-looking precancerous lesions. So the most common precancerous lesions I see are, one, the white patches, those leukoplakias, and where dentists are very good, what they're very good at doing is they're good at spotting it, but then they stop short, all right? So they spot it, and then they say, well, that looks innocent, and the patient may say, well, I've had it for 10 years. My previous dentist saw it, and maybe I'm biting my tongue, maybe there's a reason for it. And a dentist will get lulled into this false sense of security and say, you know what, let's see in 6 months. Let's see what it looks like. And that's not ideal because it looks innocent until it doesn't look innocent.
Interesting. Well, to that point, walk us through that decision-making tree. When should we biopsy? When should we refer? And when is watching and waiting an okay thing to do?
Well, I'm hesitant to answer that question because you'll see I'm a very simple-minded person. But if you get into the mind of an oral pathologist, and I think the way I think about it is different, is similar to my colleagues. If you use, for example, a white plaque, what I do when I see any sort of white lesion is I try to put it into one of three baskets in my mind. Basket one is this is obviously safe. So you see patients with linea alba all the time, that white spot. We know it's safe. We leave it. The second basket is I know this is a problem. This is precancer or cancer, like a thick white plaque in the floor of the mouth. This isn't due to a rough filling. This needs a biopsy. The third basket is the most difficult, which is it looks safe enough, but I'm not entirely sure. So if you use the example of a thin white patch on the side of your tongue, it could be friction. I'm not sure. What I will do in this situation is I'll see, is there something causing it, like a rough filling? Could this be adjusted? But if it's not resolving, I'll biopsy it. What I don't do, which is where people make mistakes, is they'll say, it looks fine. Let's just keep an eye on it. Because like I said, it looks safe until it's not.
Mm-hmm. Interesting.
Mm-hmm.
We're in the era of AI technology and salivary biomarkers and AI screening tools. They're showing a lot of promise in research. Are we ready for these technologies now in clinical practice, or is experienced clinical judgment still irreplaceable?
Yeah, well, definitely that. I think clinical judgment is irreplaceable. Gary, have you ever brought any of your kids to work, for Bring Your Kids to Work Day?
Sure, when they were little.
Okay, I did that recently, and I think I was a bit of a disappointment because my kid was not impressed by the lack of technology. It was just me, the patient, my eyes, my brain. With that being said, there are some new tools for our toolbox. You mentioned biomarkers, salivary biomarkers. The idea here is that if you have a cancer in your mouth, it's producing proteins. We can detect these proteins, and you can imagine a future where a patient spits on a glass slide onto a panel of biomarkers, and we can say, "Oh boy, there could be cancer in your mouth." It's tempting, it's exciting. It just doesn't exist right now. Where most of the excitement is going, especially these days, is AI. And you could imagine you see a patient for an endodontic consult and you notice, a red patch. And you say, this is probably nothing, but let's take a photo. You put it into your smartphone and it generates an answer. This must be biopsy. This is safe. There are actually some retrospective and a few prospective studies using this, but really nothing that's reached mainstream. So the net result is exciting new tools, definitely something for the future. But in 2025, your patient is going to rely upon just me, my hands, and my brain.
It's interesting because there are apps that you can take a picture of the mole or the lesion and send it off, and it goes to a doctor. The doctor comes back and says, it could be this, could be that. Go see your doctor.
Correct. And I've actually tried some of these apps, and I've been horrified how accurate they are. So it makes me wonder about my long-term future. I think in our lifetime, I'll probably still have a job.
So your 2023 survey found that, most dentists screen regularly. Only about half of them identify common presentations of oral cancer, and very few discuss the risk factors with their patients. So what are we missing in our training and our daily practice?
Right. So yeah, that was an interesting study we did, and it kind of reinforced something I said before. Dentists, they care, they want to help, they want to look, they want to contribute. With that being said, there are knowledge gaps. Dentists don't always appreciate, what cancer looks like or what the risk factors are. I think there's probably a whole slew of different possibilities of why that's the case. I think one obvious source is dental school. I think if dental school is 20 years, we'd be good. We could really have a solid focus on an oral cancer. That's just not going to happen. There's lots of things to cover in 4 years. So oral cancer is a fairly minor component. And then, of course, when you get out into practice, you're being pulled in a million different directions. Oral pathology, while important, you're not practicing it every day. So it kind of falls out of the everyday and becomes less and less in the front of your mind. So the net result is that you have to stay up to date. You have to listen to things like this. You have to go to lectures. You have to read. Speaking of lectures, I once went to a lecture in Quebec City. It was this guy, Gary Glassman, who was talking, and he said, when you go to a lecture, you're going to remember a few things. And I actually don't remember what you lectured on, but I did remember that. And what I would hope people remember from this is oral cancer. Is it rare? No. Is it uncommon? Yes, you will see it. I would hope you would remember that there's real consequences of not being vigilant, okay, both for you and the patient. And I'd say the other thing to remember, and probably most important, is when in doubt, ask. All right. So there's lots of us in the community who are smart, lots of specialists, lots of colleagues, lots of GPs, people who work across the hall from you. Ask. No ego in pathology.
Interesting.
Mhm.
Well, thanks for your valuable insights.
Thank you.
It's been very eye-opening and hoping to our listeners as well. And what I've learned is that every dental visit represents a screening opportunity to detect oral cancer before it's too late.
Absolutely.
And I think that's a great takeaway for everyone.
Yeah.
So we're going to continue exploring innovations in diagnostics and patient care right here on Dental Talk. See you next time.